All right, good evening, everyone. Dr. Randall Gates, board certified chiropractic neurologist, also a chiropractic physician at Gates Brain Health. Tonight I'm talking about peripheral neuropathy. This is the second part in my series, and last week I did an overview of neuropathy, some of the challenges that neuropathy patients are facing, and maybe some tips on how to talk to your neurologist when you're wanting further testing if you have a cause of neuropathy other than diabetes, which if you don't have diabetes, you have some other non-diabetic cause. So in tonight's broadcast, hopefully, and good evening to everyone who's joining, hopefully I'll be able to give you some overviews of the newest research on peripheral neuropathy relative to blood sugar regulation. Uh, Within the pie chart, so to speak, of peripheral neuropathy, about half of cases are made up of diabetics. The other half of the pie actually has a considerable amount due to prediabetes, or more appropriately termed impaired glucose tolerance. And I'll talk about some of those studies tonight. We're actually probably wanting to change the definition of pre-diabetic or impaired glucose tolerance neuropathy and diabetic neuropathy to a metabolic syndrome neuropathy. We being some of the authors who are proposing this, I doubt that's going to gain traction anytime soon, but at least we'll start kicking around the idea for those who know about it. So without further ado, I'm going to show this in the screen and go the other way around. So this is the article I'm citing. It's from the Journal of Diabetes Investigation, open access. Dr. Steino, as well as Dr. Albert G. Smith. Dr. Smith is from the University of Utah Medical Center. He's a neuromuscular specialist, and he's done a lot of the research regarding this relationship between idiopathic peripheral neuropathy and metabolic syndrome. We could also say prediabetes. We could also say impaired glucose tolerance. And I'll talk about what that means a little bit more. And again, hi to everyone who's joining. Let me send you a shout out. So with that being said, Dr. Smith, I think there's also a gentleman named Dr. Singleton who is at the University of Utah. They did a lot of this research, as I'm mentioning, and it's really important because, again, so many neuropathy patients out there are told, you know, you don't have diabetes, we don't know what's wrong with you. And in today's day and age, that's not really an acceptable answer. Now, how do we categorize what diabetes is, what prediabetes is? That's what we're going to talk about next. So normal blood sugar control is when you go to your doctor and you have something done called a metabolic panel. Most typically in your fasting glucose is below 100, basically, milligrams per deciliter. Now, if you have prediabetes and your number starts popping up above 100 and you're between 100 and 125, which a lot of people are, and your doctor may say something about it, they may not say something about it. Keep in mind, from an internal medicine or general practice standpoint, being pre-diabetic has a whole different meaning than if you have peripheral neuropathy. So that's a common point that I want to drive home. So often the neuropathy patient goes in and their doctor says, oh, you know, your blood sugar is just a little bit high, but that's no big deal. Well, from an internal medicine standpoint, yeah, it can be no big deal, but from a peripheral neuropathy standpoint, that can be a huge deal. So something really, really important. Diabetes is when your blood sugar goes above 126, and usually it has to be seen on multiple occasions. Now, the 2-hour oral glucose tolerance test I'll talk about throughout this talk is really, really important that this is done for idiopathic neuropathy patients. We're finding that it's more accurate for identifying when there is a metabolic syndrome or blood sugar dysregulation problem as the cause of peripheral neuropathy. It is where a person consumes 75 grams of, I think it's anhydrous, dextrose, basically sugar solution, and you drink that sugar solution, then they take your glucose every 30 minutes for 2 hours. And they watch to see what your glucose does. A normal finding is for your glucose to be below 140. A pre-diabetic range, or what we call impaired glucose tolerance, is between 140 and 199. Also, impaired glucose tolerance can refer to diabetes, where you go above 200 after drinking this 75-gram bolus of carbohydrate. The oral glucose tolerance test used to be done more commonly in the past, many decades ago. Now it is uncommonly performed. They've actually shown that though it's really good at demonstrating idiopathic causes, let me say it this way, though it's good at demonstrating a blood sugar cause in idiopathic cases of peripheral neuropathy, it does need to be repeated more typically in females. By that, I mean a female who has impaired glucose tolerance may need to have the test done multiple times for it to show up. And I've seen this clinically, and it can fool you. I've seen it a lot lately. I've had a lot of thin patients who are female, and they have normal fasting glucose. They have normal hemoglobin A1Cs. We had done some glucose tolerance testing, and it wasn't until more thorough, repeated glucose tolerance tests were performed that ultimately it showed up. So, just a word to the wise, so to speak, about that issue. Hemoglobin A1C, this is how much sugar is basically connected to your hemoglobin. Hemoglobin lasts for several months, and so basically we say this is an approximation of your 3-month measure of blood sugar. Hemoglobin A1C below 5.7% is normal. Between 5.7 and 6.4% is considered pre-diabetic. Above 6.4, once you get into the 6.5 range, now we're talking diabetes. So you probably know a lot of this, but it's just good to review. Of particular importance, which I'll highlight later, is that oftentimes, again, the fasting glucose and the hemoglobin A1C may be deceiving in the world of cryptogenic sensory peripheral neuropathy cases. Cryptogenic meaning we don't know the cause, or cryptic meaning kind of elusive. So we have that. Now, let me see here. We're going to hide that one. And then I'm going to show this one in stream. I always do that backwards. Now, how do we diagnose metabolic syndrome? Metabolic syndrome has a number of different criteria. It has a number of different classifications. But basically, what most people agree on is some overlapping features of 3 out of these 5. So if you have abdominal obesity, which for a guy is going to be a waist circumference above 40 inches, and men above 35 inches in women. Hypertriglyceridemia, so triglycerides, which are seen on your lipid panel, if they're above 150, or taking a drug for elevated triglycerides, that's another one. Reduced HDL cholesterol below 40 in men, or below 50 in women, or taking a drug for reduced HDL. Hypertension, where your blood pressure is above 130 on the systolic, that's the top number, and or above 85 on the diastolic, or if a person is taking an antihypertensive agent or has a history of hypertension. And then hyperglycemia, insulin resistance, fasting glucose above 100, or taking a drug for elevated glucose. So these are the criterion for diagnosing metabolic syndrome. So if someone has 3 out of these 5, generally they're regarded as having metabolic syndrome. It's pretty easy to have these, and we're finding that a large percentage of Americans have metabolic syndrome. And again, reviewing the statistics, 1/3 of the American population is pre-diabetic. About 10% of the American population right now is diabetic. It is anticipated that those numbers are going to grow, literally and figuratively through time. So things to be aware of. All right. So we're going to hide this slide. And I always do it. Okay, there we go. So it's late for those who are watching, 11:18 p.m. Pacific time. So here is a nice picture of an intraepidermal nerve fiber density test, which is really, really, really important for anyone who has neuropathy symptoms. Causes such as the neck or the brain have been ruled out, and basically maybe a nerve conduction velocity and EMG test are normal, which are looking at large fibers. We want to look at the small fibers because those are not tested via the nerve conduction velocity and EMG testing. So to go into that a little bit more, when you look at a nerve, think of a nerve as a pipe. Within a pipe, we have a bunch of, let's say, coaxial cables, and some of those cables are going to have large diameters, some are going to have small diameters. The large diameter nerves, so to speak, within, let's say, your sciatic nerve, are transmitting signals such as the position of your toes. If I were to put a tuning fork, a vibration stimulus on the toe, would you feel that? Also, other impulses being sent down to the toe, for example, for muscle movement. Those are large diameter functions. Whereas mechanical and thermal pain are going to be carried through what we refer to as small fibers, collectively the A delta and C fiber types. And these small fibers lack myelination. So big fibers transmit really quickly, I think on the order of around 70 meters per second, sometimes 120 meters per second. And the small diameter nerves may be in the range of 2 meters per second. So they transmit really, really slow. And they don't have a lot of myelin, so they don't have a lot of insulation around them. And we see here in the top part of the figure, part A, this is what a normal intraepidermal nerve fiber density test should look like. What is that? Basically, it's a skin punch biopsy where you take a biopsy of skin out and you look at it under a microscope. And basically, there's uniform quantification now of of how many nerve fibers there should be in a given density of skin. And here in section B, we can see this is what reduced nerve fiber density looks like. So for those of you who have burning pain at night, particularly or if your feet burn, or if you're going out in the middle of the night standing on cold concrete, if your feet are turning really red, if you're in bed and the covers bother your feet and you have to stick them outside of the covers, these are all typical features of what we call small fiber peripheral neuropathy, which is especially common in prediabetes. So something, again, to be aware of. Now, because the intraepidermal nerve fiber density test is, it's a skin punch biopsy. It's taking some skin out of a person. Here we go. I got it right. There are other tests being explored. This is a corneal confocal microscopy test. This is normal over here in section A. Section B is abnormal. You can see reduced nerve fiber density in the cornea. So probably this is going to become the gold standard in the future. It's just been discussed, I think, in the last 10 years more commonly regarding this being the test for diagnosing prediabetic small fiber neuropathy and maybe other cases of small fiber neuropathy. But again, this will be less invasive and it may be more clinically easily done, so to speak, than doing the skin punch biopsy. Other options include the QSART test, referring to quantitative pseudomotor axonal reflex technique, which is basically a sweat test. Your small fiber nerves are involved with sweating. Okay, so we'll hide this one and we'll show this one in stream. Oh, goodness. Okay, back to that. So one interesting thing, there's this big research study done called the Diabetes Clinical Control Trial. Diabetes and Complications Clinical Control Trial, I think that's the name of it, where they followed, I think it was around 1,446 or 1,440 some odd type 1 diabetic patients, and they stratified them into different groups of strict diabetic control or loose diabetic control. And they, in essence, found that for the type 1 diabetics, when they rigorously controlled their blood sugar, that their incidence of developing peripheral neuropathy was much, much, much less. And so from it, a lot of clinicians, including myself, gleaned that, well, we need to be embarking on that model for all cases of diabetic issues, particularly if we're concerned about the development of diabetic neuropathy, or maybe if it has developed, can we really try to reduce blood sugar to help that person with their neuropathy? What we're finding is that doesn't really hold true for type 2 diabetes or this umbrella of metabolic syndrome type peripheral neuropathies. And again, these two authors are almost arguing that, in essence, metabolic syndrome, impaired glucose tolerance, prediabetes, and diabetes are all the same condition when it comes to neuropathy. It's just different percentages of those with each, like metabolic syndrome, prediabetes versus diabetes, different percentages of those categories are going to go on to develop peripheral neuropathy. So other interesting tidbits that I think are good for you to know is that about 50% of type 2 diabetic patients will develop peripheral neuropathy. So again, 10% of the American population is diabetic. About 30% is pre-diabetic. A lot of those pre-diabetic individuals are going to develop diabetes ultimately. And so right now, just half of that 10% is 5% of our population is going to have diabetic peripheral neuropathy. And if we look at the numbers, that's going to be about 15 million Americans just with diabetic peripheral neuropathy. What they also find is that at the time of diagnosis of diabetes, about 20% of those individuals will have signs of peripheral neuropathy. So they're not complaining of neuropathy at that point, but when their diabetes is diagnosed, 20% of those people have signs of neuropathy. So it means that the neuropathy is coming on, they just don't know it yet, which is what prompted a lot of research into, well, hey, let's really look into those with prediabetes, those with metabolic syndrome, those with impaired glucose tolerance. And oh my goodness, when we look at these groups, a lot more of them have peripheral neuropathy than we would expect or see in control participants. And vice versa, when we look at idiopathic peripheral neuropathy, again, think of that other half of the pie, the other 50%, then a substantial percentage of them have impaired glucose tolerance, around 36%, if I remember right. So they do these studies and they take these control participants they take these individuals with idiopathic peripheral neuropathy who don't have diabetes at the time of the investigation. They do a glucose tolerance test. They have them drink the 75 grams of glucose. And then lo and behold, they find that like 36% of them have impaired glucose tolerance, so like a pre-diabetic cause of their peripheral neuropathy, and then around 20% had diabetes, and they were showing up being completely normal on their fasting glucose and normal on their hemoglobin A1C. So that's really important for everyone in the neuropathy world to get. Now, these authors made this great diagram showing that this is probably more the pathology of the metabolic syndrome umbrella of neuropathies, which includes diabetes, prediabetes, and metabolic syndrome. And their concept is basically that the insulin resistance and the obesity lead to these elements of increased free fatty acids, high hyperglycemia, adipokines, which are inflammatory chemicals from the fatty tissue, a lot of reactive oxygenated species, basically a lot of immune activation and inflammation leading to endothelial injury, so injury to the blood vessels, reduced vascular reactivity, and as a consequence, direct nerve injury. So it's thought that there probably are some pretty strong vascular mechanisms going on in those with impaired glucose tolerance, prediabetes, metabolic syndrome, and diabetes. And maybe that, as much as anything, is leading to the nerve injury. The good news is that, let me hide this one. The good news is that these small fiber nerves do have the capacity to regenerate. Now, your skin, your epidermis, is always growing new skin cells, and because of that, the epidermis is always kind of reorganizing itself, and with that, the small fiber nerves have to be able to reorganize themselves also. And so it's thought that the small fiber nerves do have regenerative capacity, which is where now there have been a lot of research studies looking at, well, let's do exercise programs and dietary changes with diabetics, pre-diabetics, metabolic syndrome patients. And what they find is that there can be some improvement in small fiber regeneration and symptoms in this group of metabolic syndrome umbrella neuropathies. So I think this is all pretty fascinating. Hide that, and I think that pretty well summarizes it. So the take-home points are that if you know someone with idiopathic or cryptogenic peripheral neuropathy, you really want to ask them or ask yourself, have I had an impaired, or let me say it this way, an oral glucose tolerance test? And if they are a female, have they had multiple glucose tolerance tests to validate or ascertain their blood sugar function? And if that is the case and they do have impaired glucose tolerance, what are they doing from a dietary standpoint? What are they doing from an exercise standpoint to work with that condition? And it's also important to realize that it's probably more of a vascular injury as well as an immune activation issue with this metabolic syndrome umbrella of neuropathies, including diabetes type 2, prediabetes, and metabolic syndrome. Whereas it may more be just a pure glucose relationship in type 1 diabetes, where excessive glucose accumulates in certain tissues like the eyes, the kidneys, and nerve tissue, becomes osmotically active through sorbitol pathways, which then leads to nerve injury. So that's the delineation. If you have any questions, let me know. Thank you all for watching, and I hope you have a fantastic night. Okay.